All right, let's get right into it. If you're prepping for your FRCA Viva, you know pulmonary aspiration is a massive, high-stakes topic. In this guide, we're going to break down everything you need to know to absolutely nail that question with a smooth, structured, and super confident answer. Okay, let's do this.
For a patient, this is what anesthesia looks like. It's a moment of complete and total trust. But for us, on our side of the drapes, it's a moment of huge responsibility. And pulmonary aspiration, well, even though it's pretty rare in elective work, it's one of those complications that can turn a routine case into an absolute nightmare in a heartbeat.
So why is this such a big deal for your Viva? Well, check this out. The landmark Fourth National Audit Project, NAP4, found that pulmonary aspiration was the single most common cause of death related to anesthesia, 50%. That's a staggering, sobering number, and it's exactly why every single one of us has to be an expert in preventing and managing it.
Okay, so here's how we're going to tackle this, just like you would in a perfect Viva answer. We'll start by defining the problem, then dig into why it happens, talk about how to spot the at-risk patient, cover the absolute cornerstone of prevention, and then finally, run through exactly what to do when it happens.
First things first, what are we actually talking about here? Because, a killer Viva answer always starts with a rock-solid, crisp definition. Okay, so this is it. This is the definition you need to have locked and loaded. It's the inhalation of stuff that shouldn't be there, gastric contents, blood, whatever, that gets past the glottis and down below the true vocal cords. That's the key part. It's precise, it covers everything, and it's exactly what the examiner wants to hear. All right, so we know what it is, but why does it happen? See, in our normal, awake state, our body has all these great defenses to stop this. But anesthesia? It comes along and systematically takes those defenses down one by one. So it all comes down to this idea of barrier pressure. Think of your lower esophageal sphincter, the LOS, as a little gatekeeper at the top of your stomach. Normally, it's squeezed tight, keeping everything down. But many of our drugs, propofol, opioids, you name it, relax that sphincter. At the same time, things like laparoscopic surgery can increase the pressure inside the stomach. The barrier gets weaker, and suddenly that gate is wide open for reflux.
And I love this slide. This is the Swiss cheese model, and it's the perfect way to think about this. Aspiration is rarely just one single failure. It's a cascade. It's like you need a full stomach and a sleepy esophageal sphincter, and you've lost your protective airway reflexes. All the holes in the different slices of cheese have to line up perfectly for that disaster to get through.
Okay, so that's the theory. Now, let's get practical. This is your core job as an anesthetist. Figuring out which patients are walking in with all those holes in the cheese already lined up against them, long before you even draw up your first drug. So in your Viva, this is how you should lay it out. It's clean, it's logical, break it down into categories. You've got patient factors, things like being non-fasted, obesity, pregnancy. Then you have surgical factors. Emergencies are always top of the list, but also think about surgical position. And finally, anesthetic factors. A known difficult airway or not being deep enough dramatically ramps up the risk. All right, so we've spotted the patient who's at risk. Now for the million-dollar question. What are we actually going to do about it? This is probably the most important part of your answer, because with aspiration, prevention is absolutely everything. Of course, Prevention 101 is fasting. We all know the classic 6-4-2-hour rule. It's worth knowing that some newer guidelines are a bit more liberal, especially for kids. But honestly, the most important thing to remember here, the big takeaway, an emergency patient is always considered to have a full stomach. Always. It doesn't matter when they last ate. They are high risk, period. Now, for those high-risk folks, we do have some drugs in our toolkit. We can give something like sodium citrate to make the stomach contents less acidic, or use H2 blockers and PPIs to reduce acid production. But let me be clear, this is not something you do for every patient. These are reserved only for those patients you've identified as being at significant risk. And here it is, the absolute cornerstone of prevention, the rapid sequence induction, or RSI. The whole point of this drill is to make the time between the patient going to sleep and having a cuff tube in their airway as short as humanly possible. So you pre-oxygenate like your life depends on it, you get cricoid pressure on, you give your induction agent and your muscle relaxant back to back, and you get that tube in without bagging them. No way. Okay, so the moment you say RSI and cricoid pressure in your Viva, you know the examiner's eyes are gonna light up. This is one of the all-time classic Viva debates in anesthesia, and you have got to be ready to talk about the controversy. The key here is to show you can see both sides of the coin. You start by saying,
Look, for decades, this has been our standard of care, based on the principle of squashing the esophagus shut. But then you have to pivot and discuss the other side, that the evidence for it is actually pretty weak, that it can totally wreck your view, and, this is critical, that you absolutely must take it off if the patient is actively vomiting, or you risk rupturing their esophagus. Showing that balanced view is what makes you look like a really thoughtful clinician.
Okay, so let's say the worst happens. You've done everything right, but aspiration still occurs. This final part of your answer is all about showing you can take charge of a crisis calmly, logically, and effectively. First, you've got to recognize it, and it's not always a massive, obvious event. Sometimes, sure, you see vomit in the airway, but a lot of the time it's more subtle. You might just see the SATs start to drop, or your ventilator alarms with high pressures, or you hear a new wheeze. You need to have that high index of suspicion. The second you even think it's aspiration, you have to act instantly. This is a drill you should know by heart. First, you call for help. Then get the patient head down, Trendelenburg, use gravity to help you. Suction out the mouth and pharynx like crazy. Get them on 100% oxygen, secure the airway with an RSI, and this next bit is so important. You suction down the tube before you give that first breath. You do not want to blow that stuff further down into the lungs. Okay, I need to be crystal clear about this next point because it's a huge one for your Viva and for patient safety. The initial problem here is a chemical burn in the lungs, a chemical pneumonitis. It is not an infection, so giving antibiotics right away doesn't help and can actually cause harm by breeding resistance. Same goes for steroids. They've been shown to have no benefit. The treatment is purely supportive. All right, let's wrap this up. If you remember nothing else for your Viva, remember these things. Know that NAP4 stat. It's a killer opening. Structure your risk assessment into those 3 categories. Know that RSI is your go-to for prevention. Be ready for that cric-weight pressure debate, memorize that immediate management drill, and finally, know that treatment is supportive. No routine antibiotics, no steroids. And I'll leave you with this final thought, a classic kind of question to really test your clinical judgment. You've dealt with the immediate crisis, but it's not over. The surgeon wants to know if you can carry on. So, what are you going to weigh up? The patient's stability? How bad the aspiration was? How urgent is this surgery really? Thinking through these next steps, that's what really separates a pass from a great pass.